Good morning. This is Babak Larian, Dr. Larian, and today we're doing salivary or parotid Q&A right now. It's a very strange time. Things are very different. Hopefully I can do this lecture and help you guys kind of put it into perspective if you're being affected by something like this, okay? To put some fears to rest and give you some ideas about how important it is to address it, or do you have time in this very strange moment in history to kind of sit back and take a deep breath and give yourself an opportunity and some time to pursue it, okay? And I think that's really important. So I'm going to turn this around and go through a series of slides I've made to kind of explain why, the reasoning behind all this, okay? All right, so salivary gland tumors. There's a variety of tumors that can happen in the salivary glands, right? And there's a number of different glands. We have the parotid gland, which is on the side of our face, the submandibular gland, which is right underneath the jaw. Here we go. So this is the parotid. This is the submandibular gland. These are the sublingual glands, right? And there's multiple tiny small glands on the palate, on your lips, on your cheeks, in the back of your throat, everywhere, right? And the functionality of these glands is to produce saliva that through the ducts go into the mouth, right? And by doing this, they lubricate the mouth, they wash away some of the bacteria that's in there, they begin the process of digestion. There's a lot of functionality. So these are very important glands, but fortunately you have multiples of them. You have two parotids, one on each side, two submandibulars, multiple tiny sublinguals on each side, and then about 200 other tiny little glands inside your mouth. And if you were to look on the inside of your lip, there are multiple little bumps on there, and those bumps each are little saliva glands. On the palate, on the roof of your mouth, if you actually open your mouth and look inside, and you can see that sometimes you have these drops of saliva being formed on the roof in and of itself. So we're an amazing machine, amazing creatures, right? In any case, moving on. So 80% of the tumors that happen in the salivary glands happen in the parotid gland. 15% happen in submandibular gland, and 5% in the rest of the minor glands, the sublingual glands and the other glands that we were talking about. The interesting thing, and I'd say somewhat fortunate, is that of the tumors that happen in the parotid, only 20% are cancerous, right? So most of the tumors happen in the parotid gland, only 20% are cancerous. 50% of the tumors in the submandibular gland are cancerous, and 70% of the ones in the other minor glands, right? So the tumors can occur in any of the glands, right? More commonly in the parotid, but it can happen in any of them, inside the mouth, on the palate, on the back of the tongue, anywhere. Usually, most of them don't have any symptoms. So a lump in the parotid gland or submandibular gland, or even the smaller ones, just may present as a lump in there that you feel, right? But if it's deeper in those areas, or in an area where it's not visible, like on the back of the tongue or palate, you may not actually see or sense it, right? So usually they don't have symptoms. So the World Health Organization has kind of come up with a classification system for tumors, salivary gland tumors. There's 15 benign tumors that happen in the salivary gland, pleomorphic adenoma being the most common at 72%, and Warthin's at 16%, basal cell adenoma, myopithelioma, oncocytoma, and there's a whole bunch of other ones that can occur, right? Then in terms of the cancers, There's 20 different types, right? The most common being mucoepidermoid, followed by adenoid cystic carcinoma, followed by adenocarcinoma, and then malignant mixed. Malignant mixed is pleomorphic adenoma that has transformed into a cancer, right? So the fourth common cancer in the parotid gland or in the salivary glands is a cancer that develops from a benign tumor that in time transforms into a cancer. This is a very odd situation because most benign tumors do not. So I'm going to go back one slide. When you look at this list of 15, none of the other ones become cancers. Only pleomorphic adenoma has the potential of becoming cancers. Warthin's tumors, some people will argue, is not even exactly a tumor, and it's an immune reaction or inflammatory process. Happens most often in smokers. And there's an incidence of lymphoma because Warthin's tumors, the other name for Warthin's tumors is cyst adenoma lymphomatosum, which means that it's a lymphatic reaction. So within that lymphatic reaction, there's a potential that one or two cells can in time transform, but I don't think that's specific to the salivary glands. That's in general. When there's an abundance of lymphoid tissue, there's a potential that one or some can potentially change, right? In any case, so pleomorphic adenoma, the most common tumor in the salivary glands, in the parotid glands, is one that's concerning because it doesn't start off as a cancer, but potentially can become one. All right, so let's move on. So when you look at overall incidence of tumors, 68% overall are pleomorphic adenoma, and 32% everything else, right? So when someone has a lump on their salivary glands, odds are still in favor that it is a benign tumor, right? So, how does a salivary tumor start? Let me come to this slide again. All right. So, why are there so many different kinds? Because there are different components to the salivary glands. These are the areas, the acini that makes saliva. The saliva goes here through the ductal system. These are the intercalated ducts, and then they come to the main ducts that join to send the saliva all the way out, right? There's muscle tissue here that contracts and squeezes the acini to squeeze the saliva, and there's covering on it. And so there's multiple different components in a salivary gland, and they can turn into cancer cells. Now let me actually give you a better view of it. So again, the acini, the ductal system, muscles around them, right? And so these are called the intercalated ducts. These are striated ducts and excretory ducts, right? Saliva flows that way, right? It's made here and it goes that way. These different cells that you see here, some are stem cells, the purple ones here, and yellow ones are progenitor. So the stem cells turn into progenitor cells, and the progenitor cells turn into intercalated ducts, striated ducts, acini, myoepithelial cells, and so on and so forth. And so this stem cell being here that has the potential of turning into anything is the reason there's so many different kinds of salivary gland tumors, because there's so many different potentials that this stem cell has. All right, so pleomorphic adenoma. Let's talk about pleomorphic adenoma, in that it's the most common. Under the microscope, there's many different things you can see when you cut a pleomorphic adenoma. You can see here the actual cells that produce the saliva, the serous acini and mucinous. So the different types of saliva, more watery saliva, more mucousy saliva, based on which component is making the saliva. And these are the ducts. You can see there's a channel in the middle of them, right? And that's where the saliva goes through. There's some fat in there. The salivary tissue has a little bit of a texture of breast tissue. Less fatty, so not quite so much, but similar, because it's a gland that produces something, a liquid that's excreted. So its basic makeup is very similar. And again, you can see these are ducts. Okay, these are the glands. These are the mucin-producing glands, right? And the ducts that go through, and these are the muscles around them, and the tissue around these ductal systems. Anyways, so there are different kinds of pleomorphic adenoma, right? They're very cellular, like this area is a cellular pleomorphic adenoma. Sometimes you have one that looks like this entirely. Some are myxoid, which is half this fibrous tissue around it and half cells or more fibrous tissue, right? And so it comes in many different versions. But the ultimate point is that it's the same type of disease and tumor, right? Now, salivary glands have a capsule around them. Pleomorphic adenomas, so the tumor within there has a capsule too, except that the capsule of pleomorphic adenomas is not complete. And so sometimes it grows into its capsule, sometimes there's the little bulges that come out, the little legs, we call pseudopods, and sometimes there are pieces that are separated, okay? So the capsule is not complete, right? In a lot of the patients. Okay, let's move on from here to get to the more important things. So salivary tumors can be small, like this one that you see here, larger and really large. And obviously, when you have patients with these presentations, there's always a story behind it. And both of these patients had very valid reasons to have to allow this tumor to get bigger, you know? And it's very interesting when you talk to people who choose to live with things, the reasoning for them. And actually, I think if you had an opportunity to talk to these patients, you'd find their reasoning very compelling and actually very brave, in fact, to be walking around with something like that. It's a hard thing to deal with sometimes, you know, both psychologically and physically. All right, but tumors can grow in time to be larger. All right, the best first step when you have a tumor in the salivary gland is to do a needle biopsy of it if you have access to it. Right, so put a needle inside. So this is the tumor. Right, these are the branches of the facial nerve. Right, this is the parotid gland that is showing. So usually, either if the tumor is bulging out, you can do it directly, or if not so visible, you can put an ultrasound machine on the surface and watch the needle go inside the tumor so you know you're getting a sample of the tumor. So the accuracy can be about 95%. 4% of the time it can tell you that it's not cancer, but on final pathology you may find that there is some cancer. And if this suspicion is that it's lymphoma, a needle is not going to be able to get adequate amount of cells to tell you if it's a lymphoma or what type it may be. Right? There's a staging system for salivary gland. It's called the Milan reporting system. Right? And the risk of there being cancer is as assessed. So if they say suspicious for cancer, there's a 60% chance that it's cancer. When they say it is definitively cancer, it's more than 95%. When they say it's definitely benign, it's less than 5% chance of cancer. When they say it's a neoplasm of uncertain malignant potential, 35%, right? They see atypia, 20%. So there's varying degrees of potentials for being cancerous, right? So the most important thing is to do a needle biopsy, right? To see what it is. And then following that is an imaging. MRI is probably the best modality to look at it because these images, let me show you. These images are cross sections like this. If you were to look and you can see the teeth on them. So let me spin it around. This is the front of the person's head. That's the back of the head. These are the tooth roots and the teeth sockets and the teeth themselves. Earlobes, this is the parotid gland, normal parotid gland, normal parotid gland. This one has a tumor in it, which on MRI is bright white. So normal parotid gland, tumor within normal parotid gland, right? So you can see the entire tumor. I don't need to demarcate this one, right? And again here, normal parotid gland, and then tumor within a normal parotid gland. Now, I'm going to clear all this up. All right, so when they say something is superficial lobe or deep lobe, right? The designation for superficial and deep is very much dependent on the relationship of the tumor to the facial nerve. The facial nerve comes out of the skull somewhere around here. It's hard to see, you can't see the nerve on MRI. You can't see the nerve even on a CT scan. You just can see the canal where the nerve comes out of the skull on a CT scan, but you can't see it inside the gland. So somewhere around here is where it comes out. And then it starts giving branches that go to the muscles of the face, right? And let's go to the anatomy picture, right? So the facial nerve, let's see, comes out of the skull there, right? And then divides into two major branches, right? And it comes out of a hole in the skull called the stylomastoid foramen, right? Comes out of that hole. Lower branch goes to the muscles of the lower lip, muscles of the neck. The upper branch goes to the upper lip, smile muscles, eye, and also gives a branch to the forehead, right? So if you were to do a cross-section of the parotid gland here, this is cross-section 1 versus here, cross-section 2. Cross-section 1 looks like this, right? So you're looking from the top as if you're looking this way at cross-section 1, right? The facial nerve would be somewhere there, right? The jawbone would be here, right? Going all the way forward, teeth, right? And then right over the jawbone would be the muscles of chewing, both on the inside here and the outside. The tongue would be like this here, right? Anyways, so the facial nerve starts there and gives off branches, right? And then, so in this area where you only have the main trunk or potentially one or smaller branch, right? Starting at the dividing point, something like that. Anything that's superficial to this, right? All the section that's superficial to this is called the superficial lobe. All the section that's deep to it is called the deep lobe, right? There's no actual separation of the gland. The nerve just goes through the gland, and that's how you get the superficial and deep. So just based on real estate alone, you get majority of the tumors happening here, right? Because there's more space for a tumor to develop than there. So in generality, 1/5 of the gland is deep, so 1/5, and 4/5 of the gland is superficial to the nerve. So because 4/5 is superficial, most of the tumors happen superficial. Now, when you go look at the images again on the scans, again, this is the parotid gland. just like here. And you can see this tumor is completely on the surface. So most likely for this particular patient, the facial nerve is deep to it. Now this one, you can see that again, the parotid gland, the whole parotid gland is here. And this tumor seems to be on the deeper side. There isn't much parotid tissue deep to it, some superficial. So most likely this tumor is superficial and has pushed the nerve upwards, right? Or if the nerve is back here, the branches are going like this, right? As opposed to this one where the branches are deep to the nerve and going forward, right? To the muscles. This one is similar to that. There's not much parotid deep to it, so the nerve probably is squished on the side and going that way, okay? But sometimes you see this picture and instead of having the nerve go up, you have the nerve actually going deep and coming up. And so that can occur also. So until you're in the operating room, you never know what kind of tumor you're dealing with, all right? So the first most important thing is to get a needle biopsy, then get imaging, right? To see where you stand. But this is not the time. These are not the times where you have access to be able to do this, right? These are the times where you are sitting at home, you feel a lump on the side of your face and panic sets in because doctors are not necessarily in their offices and you don't know what to do, right? And so it is important for you, if you can access your doctor, to have them examine you. But if you have a lot of circumstances in your life that don't allow that, you have an elderly, sick parent at home, you don't want to be going out and exposing them to that, and you feel a lump on the side of your face on the parotid, and you feel it. So some of the things you can do yourself at home. First, you put it between your fingers and see if it moves. If it moves up and down and backwards and forwards, that's actually a good sign. It means it's not sticking to everything around it. Cancers fast-growing cancers generally like to stick to things. So if that moves, it's great. If there's no pain in it, right, then that's a good sign. If all your facial movement is full, so you're able to raise your eyebrows, wince and close your eyes tight, smile and show your teeth, and all the muscles of your face are working, then the nerve is not being injured by that. That's a good sign, right? So again, remember, 80% of the tumors in the parotid gland, 80% of tumors occur in the parotid gland and only 20% are benign. So if you have a tumor that's mobile, no pain, facial movement is intact, and it's not growing rapidly. So let's say you felt this thing 3 months ago, right? And you thought, oh, it's probably a lymph node, it'll go away. I've had a cold. And now you feel it right in the middle of Corona. You feel this thing, and it's still there, but it hasn't grown. Then the chances are this is a slow-moving process. It's telling you the personality of itself, right? So you don't need to be fearful of that because it's already telling you how it behaves. Not to say you don't need treatment. It's just to say that if you don't have access at this point in time, waiting a little while is probably not going to be a bad thing. Now, if you have something that's growing relatively rapidly, obviously you need to see a doctor right away and do a needle biopsy. Needle biopsies are very simple, and they can put numbing medicine on so that the discomfort of it is very minimal. And I do it in the office, so anyone can do it. I've done it on 7-8-year-olds, right? And 90-plus-year-olds, right? In any case, it's very doable, very simple to do, right? And so if you can have access in a safe environment to do the needle biopsy, by all means do that. That'll give you an answer, right? That can give you a sense of direction. If you don't have access, then I would say that you can hold off and watch and monitor. Now, the one question that just came up was about deep tumors. So I'm gonna flip this around and go back to the image. All right. So the question was, why do people hesitate to remove deep parotid tumors? So again, if you look at the cross section here, the parotid gland looks like this, right? And the facial nerve is somewhere around here. So if you have a tumor that's deep to the, that deep here, that looks like there's not much else deep to that, more than likely that means the nerve is superficial to it. And so, people get more hesitant to do surgery that's to a tumor that's deep to the nerve because you have to get underneath the nerve and get the tumor out. Although very doable and in the hands of someone who does it on a regular basis, not too challenging, it is something that's concerning. And so a lot of doctors who are not very much experienced with it would hesitate, right? Especially if the tumor is small, and especially if it looks like it may be a lymph node or something benign like that. They may say, I'm going to wait. The issue with the deep loop tumors is that if it is in fact a pleomorphic adenoma, it does have the potential of in time becoming cancers, right? So if you have a small deep lobe tumor, let's say 7 millimeters, it's very small. To get a needle into something, it has to be big enough to, except if this is the needle, to be able to penetrate the needle in there and get enough substance, right? The needle goes through a few times it doesn't come out, it just passes through a few times just to get enough cells within the hollow bore of the needle to put it on a slide or look at it on the microscope. It has to be big enough. So if you have this and I'm trying to put a needle like this in it, I don't have as much real estate as this, right? So the smaller the lesion, the less likely it is that the needle biopsy will be successful. So if you have a small lesion in the deep lobe, needle biopsy attempts are not successful, then there's two options. If your doctor says that based on the way it looks, he feels or she feels that it's benign, your doctor feels that this is benign, and it may potentially look like a lymph node. Let's say on the needle biopsy, they saw some lymphoid tissue. It has shape and conformation that looks like a lymph node. And over time, when they're monitoring it with scans, it's not growing, then there's a potential of saying, hey, I want to observe it, right? But if the needle biopsy was completely inconclusive, they didn't get enough cells, and the lesion is there, and it's either growing or it has an imaging on the MRI, it looks like potentially it could be a pleomorphic adenoma or a benign tumor, then if you are a younger person and you have a long life ahead of you, you don't want to leave that in there to allow it to transform into a cancer. And that's the reasoning to remove it. Now, I obviously have lots of patients that do this. I have 20% of my patients who have tumors that are deep to the facial nerve, so we take those out without any problems. In fact, I don't think I've had any issues with any of the patients who've had deep lobe tumors at all, in terms of facial nerve problems and functionality. And it's something that I'm doing all the time. And most surgeons who are doing parotid surgery all the time are dealing with it all the time, right? So it becomes a matter of experience, right? Also, it has to do with the age of the person. So if I had an 85-year-old person who came in with a small deep lobe parotid tumor, or any parotid tumor, in fact, right? And either had a needle biopsy that was benign or an inconclusive needle biopsy, what I would say to that person is that if you were my sister or mother, I would suggest that you repeat imaging and see how this thing behaves. If it's growing, then we have no choice but to remove it. But if it's staying steady, then the risks of surgery at that age versus the risk of this transforming into a cancer or being an aggressive cancer is very low because it's not growing rapidly, right? And so those are important things to consider. But if you're 30, 40, 50 years old, you're young, right? And you have this mass, you have a long life ahead of you. We have so much chemical exposure in our lives, so much toxins in the environment, food, air, hormones and preservatives and the foods and so on and so forth that we're exposed to. Then under those circumstances, what I would say that it's better to remove that tumor rather than keep it inside. And again, you have to find someone who has experience in treating this type of thing because you'll get the best results out of it, okay? Hopefully that helps. Hopefully that alleviates some fear. Again, if you have a mass in your salivary glands, either there or here, and it's mobile, but you put it between your fingers, and it's not like a knuckle, it's not hard like a knuckle, then more than likely it is of the benign flavor. And if it's not growing rapidly and you at this point don't have the opportunity to go see your doctor to assess it, then well, non-painful and your facial muscles are all moving on command, then you're probably okay to wait a couple weeks to a month to go assess it, right? If on the other hand, it feels like a rock hard and it's not mobile when you try to move it in all directions, or if you have weakness of facial nerve or you have pain within it, then I think it's important that you see a doctor sooner rather than later. Hopefully this helps. Best of luck, everyone. Please stay home as much as you can. Please take care of the people around you, family, friends, neighbors, all the elderly, all the people who took care of us, and stay safe. Take good care. Bye-bye.